All right, let's jump right into this explainer. We're looking at a literal, high-stakes biological thriller that happens right inside the human body during open-heart surgery. Seriously, it is a fascinating story of incredible medical innovation colliding head-on with our own deeply ingrained ancient biology.
To really wrap our heads around this, we have to start with the ultimate medical paradox. You know, the cardiopulmonary bypass machine, the heart-lung machine, is an absolute miracle of modern medicine. It completely takes over the pumping of blood and the breathing for a patient, which gives surgeons a perfectly still, bloodless field to repair the heart. But here is the massive catch. How does a machine designed entirely to save a patient's life simultaneously become a profound threat to the very body it's keeping alive?
And that brings us to the real villain of our story today, SIRS, or Systemic Inflammatory Response Syndrome. See, when we hook a patient up to a bypass machine, the body's immunologic security system kicks in. It's designed to seek out, sequester, and destroy anything it recognizes as foreign. So the very intervention keeping the patient alive accidentally triggers this massive internal war. It's a massive, non-physiologic shock. It starts as an attempt to restore balance, but it can rapidly spiral into severe organ dysfunction, crazy fluid shifts, and microemboli.
So here is our roadmap for today. We'll cover 1. The bypass paradox, 2. Tripping the alarm, 3. The hardware defense, 4. The chemical arsenal, and finally, 5. The multimodal future.
Okay, diving into Section 1, the bypass paradox, a miracle and a threat. Let's look at how this life-saving technology introduces such a profound shock to the system.
What's really wild here are the specific triggers. When a patient goes on bypass, their blood is suddenly touching non-endothelial, synthetic surfaces. Basically, it's hitting plastic tubing. It also hits an abnormal blood-gas interface. Plus, the human heart beats with a pulsatile flow, right? But the machine converts that to a continuous laminar flow. Throw in deep hypothermia to protect the brain and global myocardial ischemia, which is where the heart is temporarily deprived of oxygen, and you've got the perfect storm. The body essentially panics. It senses widespread trauma.
Moving on to Section 2, Tripping the Alarm, the anatomy of the attack. We need to look at exactly how the body's microscopic security system detects the bypass machine and sounds the horn.
The inflammatory cascade following bypass initiation is incredibly complex. It's really multifactorial. Starting with the initial triggers, the reaction basically cascades down through various pathways. We're talking complement, coagulation, cytokines, and it leads to widespread immune activation. If we don't keep it in check, this cascades all the way down to end organ dysfunction. We're talking damage to the kidneys, the lungs, or even the brain. Let's break down those primary initiating factors, because there are 3 main triggers for the body's emergency broadcast system. First up is contact activation, literally just the blood touching those foreign materials. Second is ischemia and reperfusion. The sudden loss and then the abrupt, forceful restoration of oxygen causes immense cellular shock and dumps free radicals into the system. And third, and this one is honestly kind of terrifying, endotoxemia. During bypass, blood flow gets redirected, which causes a temporary low-flow state to the gut. This drop actually allows endotoxins from gram-negative bacteria living in our own intestines to slip right into the bloodstream, which powerfully activates the immune system. And all of that kicks off an absolute domino effect as the body mounts its defense. Literally, the second blood hits the foreign material of the circuit, a protein called factor 12 gets activated. Then, factor 12 converts prekallikrein to kallikrein. Kallikrein then loops back, makes even more factor 12, and simultaneously promotes the conversion of plasminogen to plasmin. It is a rapid-fire amplifying feedback loop.
Now, crucially, this contact activation doesn't just happen in a vacuum. It kicks off a massive generation of thrombin, the enzyme that clots blood. During bypass, we obviously have to give patients high-dose heparin to prevent immediate fatal clotting in the tubes. But thrombin binds to fibrin deposited on the circuitry, and it actually changes its shape, becoming completely resistant to the heparin. It's a chaotic, highly precarious interplay between coagulation trying its hardest to clot the blood and fibrinolysis desperately trying to break those clots down.
All of this chaos triggers what we call a cytokine storm. Think of cytokines as chemical messengers. You've got pro-inflammatory signals like TNF-alpha and interleukin-6 just screaming through the bloodstream, calling in the biological SWAT team of white blood cells known as neutrophils. These neutrophils get hyperactivated and they start releasing toxic, reactive oxygen species.
To counter this, the liver rapidly pumps out anti-inflammatory signals like interleukin-10, just desperately trying to restore peace. The balance between those two opposing forces is exactly what determines if a patient recovers smoothly or suffers severe organ damage.
All right, Section 3, the hardware defense, engineering a solution. How on earth does modern medicine fight back against this? Let's look at how we use hardware to actively hide from the immune system.
The most direct way to stop the alarm is, well, to shrink the intruder. We can compare conventional bypass setups with MECC, miniature extracorporeal circulation. By eliminating massive venous reservoirs, shortening the physical length of the tubing, and coating everything to be highly biocompatible, we drastically reduce the physical footprint of the machine. It's simple math. The less plastic the blood actually touches, the milder the biological alarm.
And the clinical results of these hardware tweaks? They are absolutely staggering. By using heparin-coated circuits, where we literally bind heparin molecules right to the inside of the plastic tubing so it mimics human endothelial cells, the body doesn't recognize the plastic as strongly. On average, this microscopic camouflage reduces a patient's post-operative mechanical ventilation time by a full 80 minutes.
Furthermore, that exact same hardware modification, literally just coating the circuits, shaves a full half-day off the average hospital stay. It brilliantly illustrates that when we respect the microscopic biology of the blood, we yield massive, highly tangible clinical benefits for the patient's recovery. So, to summarize the hardware defenses engineers have cooked up, we use those heparin-coated circuits to improve biocompatibility. We deploy hemofiltration, which uses hydrostatic pressure to physically scrub the blood of excess fluid and low molecular weight inflammatory cytokines. And we even use leukocyte filtration. These are specialized filters that physically trap those hyperactivated neutrophils and monocytes so they can't re-enter the patient and damage the lungs or the kidneys.
Which brings us to Section 4, the chemical arsenal. Pharmacologic interventions. We've got the hardware, sure, but we also need a chemical arsenal to quiet those inflammatory alarm bells directly at the cellular level.
Surgeons and anesthesiologists have a seriously powerful pharmacologic toolkit at their disposal. They use drugs like apertinin, a serine protease inhibitor that forcefully blunts the inflammatory cascades and reduces bleeding. They administer heavy-duty corticosteroids, like methylprednisolone, right before surgery to suppress endotoxin release and block white blood cell activation entirely. And they deploy powerful antioxidants, like vitamin C, E, and allopurinol, to scavenge and neutralize those incredibly dangerous reactive oxygen-free radicals sweeping through the blood.
But, and this is absolutely crucial to understand, there is no magic bullet. Actually, scratch that. It's more like a high-wire tightrope walk. For example, apertinin is phenomenal at suppressing inflammation and reducing surgical blood loss. However, major multi-institutional studies, like the BART study, revealed that in certain high-risk patients, it actually doubled their risk of renal failure requiring dialysis and increased the risk of stroke. So these heavy-duty chemical weapons must be deployed with extreme precision and incredibly careful patient selection. And finally, Section 5, the multimodal future, combining forces. So, with all these complex triggers and defenses, how do we bring this all together to fully protect the patient lying on the operating table?
Well, the core thesis of modern cardiac surgery is this. You cannot rely on just one defense. You need a completely multimodal approach. At the foundation, you have your technical and circuit elements, hemofiltration, strict temperature control, leukocyte filtration, and miniature circuits. Then, at the top, you layer in your pharmacologic pretreatment and intraoperative management. Only by combining all these forces can we successfully funnel down to our ultimate goal, which is decreased systemic inflammation.
It's exactly like the researchers in our source material point out. A multimodal approach incorporating technical, circuit-specific, and pharmacologic strategies will likely yield maximal clinical benefit. The future of cardiac surgery isn't about finding one single miracle drug to stop SARS. It relies on a combined arms approach, literally layering dozens of microscopic hardware and software interventions to gently guide the body through the sheer trauma of surgery. Which leaves us with this final profound thought. Every single year, we push the boundaries of what is possible in the operating room. But the ultimate hurdle isn't just the mechanics of the heart. It's the ancient, deeply protective nature of our own biology. As our bypass machines get smaller and our pharmacologic drugs get smarter, the question really remains, will we eventually learn to perfectly mimic human biology, or will we always be locked in an arms race to outsmart our own immune systems? Definitely keep that in mind the next time you hear about a life-saving medical breakthrough.